Hello, good evening, everyone. As you know, today's webinar will be about the full arch restoration with the multi-unit abutments. The speaker is Dr. Kyriacos Rousounides from Cyprus. Dr. Rousounides was one of the speakers on our Congress in Georgia. Dr. Kyriacos, thank you for giving your yes to organizing this webinar, and I give a word to you.
Thank you for the opportunity to share my knowledge with you. I would like to start the presentation directly. I would like to welcome also all the colleagues from all over the world, and especially my colleagues here in Cyprus. The WhatsApp group will, as you will share the QR code again in the middle and at the end of the presentation. And what you didn't mention is that everything is recorded and will be shared in YouTube after. So also after the live lecture, the webinar, we can have the opportunity to answer some questions if someone sees later in the YouTube. The presentation was about the multi-unit abutments and how they help me personally and our surgical life, our prosthetic life to be easier. We start a bit general. A part of this lecture, as you, as Aktion told us, was also in Georgia last September. And some general knowledge about the multi-unit abutments is the middle part that connects the implant with the crown. It is provided in different angulations from straight, 0 degrees, 17 degrees, 30 and 45 degrees, and different heights. This gives us flexibility to insert the implant in a more in a place where more bone is, more stable is. So, and we can correct the angulation, especially when we have more than one implant to connect. Here we see some examples. This is an all-on-4 case in upper and lower jaw and how it's connected. And the parts in the middle are all the multi-units that they help us connect and paralyze the whole. These are two implants. This case here will be later in one of our cases that we see. We speak about it more. And this is a single implant that we corrected the angulation according to the bone. And we see that we have a better fit between the teeth and a straighter inside angle. These are two implants side by side, and we can see that with the right height and with the right angulation, we can parallel the implant prosthetic parts. And here is the above. Here is the above X-ray and the live picture, how we corrected this angulation. The other benefit of the multi-unit abutments is that they can refine our prosthetic and rebalance our occlusal forces. They help us distribute the chewing forces, and these lead to longer lasting results in the mouth and more successful implants. This is a partial prosthetic on multi-unit abutments. It's an immediate loading case. We connected old implants with newer implants with multi-units, and there are different pictures. The lower pictures is for a full arch, that we see that the results that they come out, they are aesthetically approved, and the screws are in areas that we better control them, and they are not also visible. We'll see in a while. This is an immediate loading case. This is a temporary this is a temporary part immediate after surgery. We see that in connection and with our lab, we can have the scan from the temporary and adjust the angle of the multi-unit some months later when we take the final impressions for the final prosthetics. So these angulations, they are in the first impression, direct after the surgery. This is the scanning of our technician. We see the position of the implants and the multi-units, and this can be also corrected before the final restoration. So these are some cases how we try to had the aesthetics before. Here we had some old cases with angulated implants, with implants that they were on abutments or screwed prosthetic parts that we had to improvise and find solutions. So we had a better aesthetic result. This is a peak restoration here, for example. The screws are all, the implants were done from another colleague, and I had to do the prosthetics here only. And we had to find solutions because the angulations were not very good. We didn't have at that time the opportunity of the multi-unit, so we've tried to correct them with single crowns glued on the skeleton here. And nowadays we have the multi-units working for us and giving us solutions. Here is we can see in the palatal side that we have the screw on the palatal side, can easily be accessed from a dentist, and it can easily be used without anything to be seen on the mouth. Here we see multiple sides from 2 sides implants, and the results are also acceptable, that are easy accessible, and they are easy and they're fine on the aesthetic. Also in the aesthetic zone, in the front area, we have here, for example, another correction. We place the implant here more palatal, and we corrected the angle so we can have here a more aesthetically approved result. And here we see another case with the same tooth. This is the lateral on both sides, and we see that the results were very acceptable. But the multi-unit abutments are a very good weapon in our hands, especially for the full arch restorations. We have done a lot of cases with multi-unit abutments. We place the multi-units directly after the surgery. I know it's a bit difficult at the beginning to find the right angle, but never mind, you can correct it later with the technician, or you can do the first impression direct after the surgery, or the first scan directly after the surgery, and you can correct it with the final. And in coordination with your technician, he will guide you to place another angulation maybe, or a lower implant, a lower abutment, so it cannot be seen after. These all cases, they are all cases of mine that they are, or some of them are from some colleagues. They show how we used to place implants. They are in a red background because most of them will not do them like this again. Most of them have sinus elevations, sinus lifts. We've tried always to place implants as straight as possible so we don't have problems with the prosthetic. We've tried to have the angulation according to the prosthetics and not according to the bone. And my opinion is that is wrong. One implant has to be stable first and after hold the prosthetic. If we don't have enough stability of the implant, you can forget the prosthetic. Nothing goes according to the prosthetics, all goes according to the bone. Everything goes according to the bone. And here we see also we've tried during the time to find other solutions like the subperiosteal implants. These are my first subperiosteal implants in the upper, in full, and in the lower jaw. Very, very complicated, very, very costly therapies. Some of them we already removed a part of it. I think this one is removed from the mouth because of an infection. You can see that you need a lot of surgical skills to place such implants. You see here that we had problems with augmentation, with covering the subperiosteal implant. We have, these are other cases with big defects that we had to place straight implants. Nowadays, everything is more corrected. You can see here, as I see here, in this mouth, we place first the subperiosteal implant, and after we needed to extract the canine here. And you see, we started using multi-unit in this area. This was directly on the time that we changed to the multi-unit abutments. And here in the green background, we see how we place our implants nowadays. We go according, we follow the bone and we place implants according to the bone quality so the implants can be more stable. And I'll show you during this lecture how we go step by step to have more predictable results with the angulated implants and how do the prosthetic also after. These are more cases like this. Here we can see how we can avoid the the mental nerve, the exit of the mental nerve, and how we can avoid here the sinus. And we have in these cases, or you can see above, with 10 teeth, 12 teeth, a hybrid prosthesis in both sides. So it's a full arch restoration completed. This was the first X-ray shows implants in the lower jaw that are longer. We have this opportunity with HGS. We ask and they offer us longer implants, longer than 16 millimeters. We have in our hands nowadays 18, 20, and 22 millimeters. And I'll show you where we can use this. For example, here in this case, or here in transsinus cases, we used here 22 degrees implants and to anchorate on both cortical bones. Here the cortical bone of the nose and here the cortical of the mouth. So, other benefits of the multi-units in general, also for general dentists, is the hygiene and how we maintain these prosthetics. These two cases, the left and right, they are cases that were done. We were placed under local anesthesia. We couldn't place the prosthetic without using the local anesthesia because we work on the bone level. We have to press the the gums around the implants. We always, for the impression, for the try-ins, for the final prosthetics, we had every time to work in a bone level that, as we understand, every time we insert bacteria in the site, inside the bone, and with the multi-units, we have the opportunity to work in the gum level. Here, for example, it's everything done above the bone on the gum level. It's everything can easily be removed. We've counted once how long we need to remove a hybrid prosthesis with 6 implants in the upper and 6 implants in the lower jaw, to clean them in the ultrasonic and put them back, clean the same time the implants. It's about 15 to 20 minutes to remove and insert them back. This is again the 1-all-on-4. We see here an angulated implant, here a straight one, and how they can easily be cleaned. You can see as surgeon and as general dentist and control everything around the gums, around the implants, and you can easily access any problem and correct it before it happens. Another benefit of this is that we give more customized and individualized treatment plans to our patients. We give solutions in cases that we couldn't do that before. And the whole work is less invasive. Most of the times is, this will sound a bit weird. Most of the times is also more cost effective. Although we use more parts, MUAs, as you know, they also cost. But if you avoid a sinus lift and the second operation, or the augmentation materials, the membranes, and all of this, and you with just inserting 2 implants with multi-units, then you can surely be more cost effective. At the same time, imagine how much time you need to find the right position for each of these abutments to insert them under local anesthesia, because they are pressing in the gums. And if one of them goes wrong, then the whole procedure doesn't sit. If you sit for these 8 abutments, you have 6 positions each. So if one doesn't sit very well, or in the right angulation, then you had to do the whole work from the beginning, and that takes time on the chair. Or this one. This one is, for me, it was a drama for me and my patient, because we had to do local anesthesia. We were not able to see exactly, unless we took an X-ray, if everything was in position. We had a lot of failures here because we cut it, we did everything with non-hex due to the paralyzation. And sometimes we have failures of the screws, and we had to remove screws from the whole prosthetics. And this is also a red one, a red flag. And nowadays we have the multi-units, and we work in this level. Everything above the gums, everything controllable. You can even remove and check if your multi-units are in position, if they are getting loose or something. And this is what we mostly use nowadays. Here we have a small video showing the same time how we fix a work on multi-units on the right and on abutments on the left. The time is almost the same, but on the right side, we don't need to insert single abutments. That's a nightmare, to insert 8 or 6 abutments and find the right positions for every abutment and every time. You don't need to clean anything of cement on the right side. On the left side, you need to clean very carefully all the cement around the abutments. And if something goes wrong, we saw a lot of cases that and a lot of implant failures due to cement, due to the cementation. And it might seem the same time, but this is already done and finished. This on the left side needed a lot of time until we got there and a lot of time after with the cleaning and everything. Here are some other cases, old cases of mine that we used to do with single abutments. And we see here a picture. It was, I don't remember if it was a discussion or a fight with me and my assistants or with me and my technical lab. And they mixed me everything, so I couldn't find the right position for anything. You can imagine how difficult it is to make this puzzle work again. You need days to correct all this and find the right abutment for all of these parts. So we have, again, the freedom works, the flexibility on the angulation, the rebalancing of the occlusal forces, and the refining of the prosthetic process. We eliminated surgical complexity, the sinus lift, and the all complicated surgical procedure. Aesthetically, we have more improved restorations. We have a better hygiene. We give more solutions, and we have more time or less time in our chair. It's our chair time is reduced. So we have again our QR code in case that someone joined later. You can scan this. You can join the group, and we can discuss anytime. Again, some of your cases maybe, or some of the cases here in the webinar, if you have any questions for that. We'll have the QR code again at the end. So multi-unit is everything very nice. It looks like a paradise, but we have some things to take care of. For example, we have to be aware of what's in the market. We thank God that we have SGS by our side, and they hear us and they help us correct a lot of the things. Here we see 3 of the implants. They are from different brands, and we see that 1, 2, 3 implants, they have here bone loss. Why? We have here again other cases with the same, and the reason why is this part here. This small, it's less than some millimeters, the round area here. This round area is this thread. If it's not closed, it causes micro movements, micro vibrations on the implant, and these micro vibrations, they cause the bone loss. They don't have the stability that we need, especially in immediate loading restorations, and this is the result after. We have, this is, if you search the internet with this picture, you'll surely find brands that they advertise this nowadays, but this caused a lot of problems in our daily life. We see a more extreme case. This is from another group, from another club, that the case was, except the straight one, that we didn't have the open thread. All the others, they had a bone loss. The case was redone. You can see here the open thread, and this is less than a millimeter, and you can see that what problem caused as this. And this is the parts that we use today, the parts of the one multi-unit abutments from SGS. They have a low profile. and the closed thread. This is very important. And this is what we actually need seeing these cases. Another thing that we need to take care is during the surgical procedures, the bone reduction and the remodeling, we need to take care of the depth and the heights. The depth is very important to have. Here, for example, is an old implant. We couldn't remove it, but we had to if we had to place it again, we place it a bit deeper so it will be in the same level and it didn't cause any problems after in our prosthetics. We had the implant there, it was good. We decided not to remove it and we adjusted the prosthetic. This is not how we do this nowadays. We better try to find one level with a bone reduction, a remodeling. Surely is not an FP1 case, it will be an FP3 case, but as a good fellow teach me, a fake papilla never shrinks. So if we have a papilla in a FP1 that at the beginning is okay, and through the years it shrinks, if we have an FP3 from the beginning, nothing shrinks, and the result stays stable. So another thing that we see here is to check if the position of the multi-unit is okay. Sometimes we place the implants, and especially in cases after extractions, we try to place the implants a bit deeper so we'll cover the resorption of the bone, the 1 or the 2 millimeters. And if we need to place especially angulated abutments, multi-unit abutments, we have the bone here touching in this bony part, or the parietal part, or how we solve this. We have in the new surgical kits of LGS, we have two instruments that they are produced after a lot of discussion. Here we see how they work. This is a pin that is inserted on the implant, and we have you can see it here. We have here this drill that is remodeling the bone around the implant, so it can accept the abutment also with a bigger angulation. This part will be removed, and we see now how easily, how we've done this in the neighbor. And we see here how easily the abutment is placed without any without touching the bone on the other side, on the parietal side. Here is the same thing with the X-ray on the left side. Here is the picture. The pin, you can find it on the upper right corner. And these are the two drills for small platforms and for wider platforms. These are the drills S6, S7, and S16, S17 on the new surgical kit. And this is the place where you, this is the drill where you remove the whole procedure. Here you can see the X-ray before with the multi-unit not in position because we had the bony part around around the implant that was on the way. And now we have, after we remodel the hole, we have the multi-unit in position. So another thing, because we had the in the past a lot of problems with broken screws, especially with small screws of the multi-units. Here is how we remove some of the parts. I think it will be in the next year's planning, like a rescue kit from SGS. I don't know when exactly, but we are trying to develop some of these parts to be either in our surgical or in an external kit, especially for broken parts, like everything as a rescue thing for prosthodontists and surgeons. What we need to take care of is the torque. This is an electric torque controller, and this is a manual. I prefer the second one because it's easier to be controlled than the electric one. The electric one, you can find it in SGS. This is from SGS, the one. The other one I ordered from, I have it from somewhere else, I don't know exactly. But this is a very useful part, especially in cases that we cannot easily reach. Upper areas or lower back areas that we cannot easily reach with this instrument. It can easily be controlled and adjusted. This instrument also helps us a lot not to lose in the mouth small parts like the small screws, the blue one. That is very, very short and very small and can easily be fall apart from our normal screwdriver. Here is attached on our wrench, our torque wrench, and it can be easily inserted in the mouth. So other things that we need to take care of, we spoke about, this is a resume, the implant market, the abutments that we use, the multi-unit especially, abutments, the depth. And for the depth, we have the new kit with the 3 instruments. We have to take care of the torque and our small parts. Now we go to some more interesting part of this webinar. We are almost in the middle. These are some cases. The first cases were shown also in Georgia last September. We added also some cases of here in this, and we'll explain some more from each case. This is a use of a 22 millimeter implant and 13 millimeter implants with an all-on 4 case. The tooth were extracted before they were replaced and extracted for the video purposes. You can see how easily we do them if they are already out. We left one molar at the back for the height. We'll see it in the X-ray at the end for the bite registration. We removed that 6 months after. Here is, you can see the 22 millimeter implant. It's huge, as you can see. And these are the 13 millimeters. I like also and here are the straight angulation. This is a part of my team. And this here is the final X-ray. You can see the 22 millimeters, how they were placed, and the 2 straight ones. Everywhere here we used, here we used 2 angulated multi-units and 2 straight ones. And this was 1 day after, or some days after. when we insert the temporaries. And we have also some pictures of the final restoration at the end. Here is the final restoration. This is 3 months after. I saw the patient some days ago. He likes to do the lower with the same way. And we see here the result, and we see here the fake papilla in an FP3 case that the fake papilla stays. It's still in place. And we go a bit deeper on this case, the first case, and we see what a bicortical anchoration really is. It's nothing new for general surgeons, for orthopedic surgeons. It's nothing unknown. We see here from femur, and here is and here from a spine bone, and we see how the screws are going through the bone from the cortical part here to the cortical at the other end. And if this screw stays before, then the whole spondylosis will fail, because if one screw doesn't sit very well and doesn't be attached in two positions, in two cortical parts, then the whole will be unbalanced. And we don't speak for mouth, we speak for the whole spine. Here is the same in a femur, and here we see the bicortical screws attached from the one side of the fracture to the other, so they can stabilize the bone with the best way possible. We've tried to copy this in the mouth, and we see here the bony part, the cortical part of the nose. We see the cortical part of the edge of the mouth. And if we have this anchoration in both parts, and also if it's 1 or 2 or 3 millimeters, even 3 millimeters in the nose, it doesn't matter. It's still the first spirals of the first threads of the implant. They are still attaching the cortical bone, and this point is where I would like to ask SGS if they can offer us another weapon. We have the 22, that's why we need the 22 millimeters. To go from here to here, we need a long implant. To go from here to here, or even if it was a bit more angulated, this implant, we needed a longer implant. And but 18, 20, and 22 millimeter implants, they are only in one diameter. We would like to have this in two diameters, for example, 3.75 and 4.5. Because if a 3.75, if we drill the whole part, and if we drill also until the area of the cortical bone of the nose or the sinus bone, and the implant spins, then we need a wider implant to close the area. Otherwise, we are done on that case, and we need to stop. And if we have the opportunity of 2 diameters minimum with 1 millimeter difference, would be a perfect way to place this kind of implants.
Doctor, we will pass this message to our R&D department.
Yeah, I already spoke with some of your colleagues, and we are planning to do this. But it's a good weapon in our hands, these longer implants, especially in this kind of cases. But in cases that the implant spins, and either we have a softer bone or we made a mistake. I also did once a mistake the assistant, they gave me their own drills, and I drilled a bit wider than normal. I cannot place the implant. If I had a wider implant, I would have placed the wider one. Anyways, we'll see how these implants, they help us also later, not only in these all-on-4 cases, but also avoiding sinus lifts. This is the same case again. This is one case that I showed in Georgia. And this is how, this is to show the case 2 and case 3 is to show you how multi-units help me keep the whole prosthetics for my patient. We see here one infection. We don't know how it happens. It came from another colleague. I needed to do something. I removed the whole one. And as you can see, the implant came together with the whole prosthetics. We had a CBCT, and we see that the defect here is a shining through defect. We see from the other side, we see here the mental nerve, the exit of the mental nerve. If I stop the video here, for example, we have here the shining through defect of the bone. We have here the mental nerve, so we cannot insert something on the back area. So we need to use the frontal area, like, for example, these parts that anatomically has nothing to be aware of, and there is also enough bone. You can see here surgically how everything goes. We have another video, I think. Yes, you can see the big defect of the after extracting the implant, and we see the angulation we followed. At the back, as we said, we couldn't go at the back because we had the mental nerve, and we went with a 45 degrees angulation in this area. We inserted the prosthetic on the other 3 abutments that we had in the mouth. We took the impression, not the normal way. We had the multi-unit showing under the empty crown, and we've tried to insert the cap inside the crown, and we took the impression like you see here in the picture. We control the fitting with the 3 parts. We have 3 legs here to control if everything fits well, and we took impression with composite, and this part was our impression. This went to the lab, and this is what came out. We see the X-ray now. As you see, we didn't use this back area, but we filled the area with augmented materials, but we used a more stable field. The more stable part of the bone was the frontal bone of the lower jaw. We have this work now more than a year in the mouth, and it's still there. Like you see, this with a bit crazy way inserting the implant, but the whole framework, the whole prosthetic didn't go in the garbage. It's still in the mouth, and it still works. The same with the case 3. This is an older case. This is a case of someone that it was very difficult to come to us through his social conditions, and we see that he came to us with a broken canine, the number 13, and the number 23 was out. He brought us the whole prosthetic like you see. You can see also that the gums were closed. We didn't have any connection with the bone. He removed it itself. He came only to us because this part was broken. Until the last tooth. And he had an attached removable prosthetic on that, and a stable 6-unit bridge in the front. We've checked if we can reposition the hole because we had the plate on the parietal area. We had the position of the one canine, and we saw that we can find the right position. So I've decided to take one impression, like before I do anything. We took this impression. We let him also bite on that to find the bite registration, and we opened the both areas to see, first of all, to see here where he extracted his own tooth, what is underneath, because our X-ray showed some defect of the bone in this area, especially on the back area, and we extracted also the 1-3. The 1-3, after it was extracted, the labial plate was missing, and we've decided to place the implant with this angulation, as you can see in the picture. Here is where the labial plate, the buccal plate, is missing. We have stabilization on the parietal plate, and we have enough bone on the region of 1-3, 1-4, 1-5. So we inserted the implant in this area, and we've tried with the multi-unit to find the right angulation to be in the mouth. We done the same in the area of 2-3. We had to face the same problem. And the only way that was possible to place the implant was to place it in the frontal area, not on the back area, because there was not enough bone on the buccal area. And here you can see how we took impression again. We had to modify a bit the impression caps of the multi-units, of our multi-units. And we inserted composite on his prosthetics, and we let him bite on that. After this, we had this impression. These are the impression caps of the multi-units for a closed tray. These are the multi-units in place after the surgery. This is the work, how it comes out from our laboratory. And you can see even here on the wings of the removable, we had placed the implant and the MUAs direct, so they are not touching the wings or any other position, direct in the middle of the tooth. This was done only because we had to work with the right abutments. The multi-units, they gave us the opportunity to come direct in the position that we wanted. And you can see here, after we screwed the 6-unit bridge, you can see also how his prosthetic works. I know this is not a normal, a standard procedure, but as I told you, it was the easiest, the cheapest, and the quickest way to recover this patient. I see this patient every 6 months for the last 1.5 to 2 years now, and the implants are there, the work is there. So maybe sometimes we have to think a bit more out of the box and see our opportunities a bit wider. So these cases, they are presented, these 3 cases, they were also presented in Georgia, as I told you, and we go in case number 4. And now we'll follow like a step-to-step protocol, how we can go from the single implant to a full arch implant without any augmentations, without any difficult surgeries, without any problems, with immediate implant placement, immediate loading, and etc. Here is a one-side implant placement immediate after extractions. Here, as you can see, number 17 and number 16, they needed to be removed. We go a bit further with the anatomical limitations. Here is the sinus, and here is the infection area. As you can see here, either you do an augmentation here or you do a sinus lift above. We've done nothing of the above. I don't always trust the augmented area, especially in these big defects, to insert implants. And I prefer the more stable bone. So we had here a palatal approach. We insert the implant with this angulation, as you can see, more palatal in the palatal triangle. And this is the implant. Okay, in this X-ray, because it's a two-dimensional X-ray, you see that it's going through the roots. It's not going through the roots. We have also a control with a 3D X-ray. This is in the palatal plate, in the palatal area. As you can see also here, is not touching any of the two premolar roots. This is the number 16, and this is the number 17. Then the defects still there. You can see the bone loss in this area after the extractions and after cleaning the infection in that area. And you can see here the pterygoid approach. We try to place the number 17 with an angulation like this to attach the plate, the pterygoid plate, and the edge cortical plate with this angulation. Here, the picture is, the X-rays is one above the other, and the lines are the same. And this is how the two implants were inserted without any sinus lifting here, without any augmentation in this area. I trust more these two implants instead of two implants in a full augmented region. And we have here case number 5. The case number 5 shows the same, but from two sides. Bilateral. We have here this area with the teeth that they need to be extracted. This one, number 17, number 15, number 27, and we had also we also removed the number 38 because we measured here the bite, and this will have problem afterwards, so we needed to be removed. You can see also here in the picture number 38 that is above the occlusion, and it will be a problem with the final prosthetics afterwards. That's why it was removed. Here we see how we manage this situation without any sinus lift on the left side, without any sinus lift on the right side. We also place straight implants. As you can see here, we have enough bone. We place the implant straight. Here we had a pterygoid implant in both sides and the transsinus implant on the other side. Here is the straight one, how it's placed. And you can see the angulation that we placed the pterygoid implant on this side. Here I can introduce you to the new kit of SGS that, to my opinion, it offers me a lot of freedom and flexibility. We have the pilot drills in two different heights here. We have we have here a Lindemann and the starting drill, and we have the pilot drills in all heights. We have all the drills in different heights, short and longer ones. Why I'm introducing this because here I need the longer one. There are sometimes mouths that they don't open very wide, or angulations that they are not easy to be reached. So we need sometimes the short drills if we don't have enough space to work. In this kit, we have also you can find also here in these three parts are the bone profilers that we introduced before, and some of the rescue kits also. This is the beginning of the rescue kit. And here are our results. You can see that the two abutments here, they are attached. We'll have a frontal cantilever, but we didn't have any other option this time. And here we'll have a normal bridge from 7, 8 to 17. You can see here also the level that we reach. Here, maybe we need to change this abutment again to a 45 degrees. And here I am trying to find maybe an angulation, better angulation. This is 45 degrees already. And this is the slide number 2, 3, I think. Yes, one of the first slides that show us again the flexibility on the angulation of the implants. Here you can see different angulation, straight implants, angulated in 45, angulated in 30 degrees, angulated in 70 degrees, and you see how we can manage all these angulations. And the last case for today is a case that it's everything done in one mouth. Here we see a pterygoid implant. Here we see a bicortical anchoration with a long implant, a 22 millimeter implant, a transsinus implant. Here we see a transnasal implant, two transnasal implants that they are attached under the nose. Surely you'll tell me why I didn't use this area here and place one implant like this. Believe me, I tried that and I failed. I'll show you the pictures. Here are the implants that they failed in these areas. Because I've tried to do a minor sinus lift here and this failed. I've tried to do another sinus lift here and it failed. So I've decided to expand the hole and do a pterygoid implant at the back. I didn't have any other choice. And this is the final result after. A transnasal implant is the implant that goes through cortical bone of the ridge and to the cortical bone of the nose floor, and the transsinus that goes through the sinus or at the very close to the sinus and goes again through the nose. These two and this one. And we have also, and you can search, you can ask me later on the group how we decide and when we decide to do a transsinus implant with bone graft or not bone graft. If it's less than 3 millimeters, the bone here in this area, we do a light membrane elevation. We have here 3 cortical anchoration, 1 cortical here, 1 cortical here, and here the cortical bone of this 3 millimeters. So this is a 3 cortical anchoration. That means this implant is stable. The other part is just to fill the area. It's not for stabilizing the implant. And the same we have here, 1 position and another 1 position, and maybe sometimes we have here another anchoration, and we reach very high torque and very stable implants with this method, as you can see here. And this is the final restoration of the above case. So we are coming slowly to the end. We have case number 1 with the bicortical anchoration, the two long implants and the 2 nasal implants. We had the 2 cases that we saved the prosthetics with the removable and one with the side implant. And we have the one case that we avoided here, the sinus lifting, with the case number 5 that we avoided both sides, the sinus lift. And if you can see here the big image, now you can, with 2 implants in the middle, you can do a Nolon 6 without any problem. If you can manage this avoidance here, this avoiding the sinuses with these techniques, you can do a full arch restoration directly. If you had here a sinus lifting and here a sinus lifting, I wouldn't do an immediate loading with the 6 implants if I had to insert 2 in the middle, because I am if I have to be stabilized 2 implants in an augmented area, another 2 here in an augmented area, and only 2 in actual bone, and do also an immediate loading, from my side of view and my experience, will be a failure. And this is a combination of the techniques that we already spoke about. You can see here how we avoid the sinuses, how we place the pterygoid implants in one or both sides. And this is what I spoke about if we had to balance on augmented area with bone grafting and do here augmentation, and do a full arch. This will be, for my opinion, a disaster. Step by step, and one step at a time, you can, colleagues that they start now with full arch, they can start, for example, with an angulated implant, a light pterygoid, or a tuber implant. The difference between the pterygoid and the tuber implant is that the one is placed bicortically on the cortical plate of the pterygoid, and the other is in the spongious bone of the tuber and the cortical bone of the edge. That is not always so stable, but if it's in a connection with other implants, it's also acceptable. We'll have the palatal approach. So the palatal approach is the approach that we used here. The way that we open palatally and we insert the implant with this angulation. The transsinus implants and the transnasal implants, like we see here and here. Handling this checklist step by step, it will find an easier way to do a full arch restoration. For any questions, any discussions, you can also reach me through the WhatsApp, either with a direct message or in the group. And we have at the end another case I call the bonus case, because it doesn't have to do with the upper jaw this time. It has to do with the lower jaw. These are implants that I placed about 20 years ago, 18 years ago. I was still afraid of reaching the nerve, the mental nerve. I was about to I wanted to do something whiter. These are old implants. They are still in the mouth without any bone loss for 18 years now. And we see here the other side that we'll speak about. And And you'll see here a bit the anatomy. We see the mental nerve canal, and you see how this channel goes through and how close it is to the infections. This is the infection area and the bone loss that we'll later see in some pictures. So here, for example, and here we can see how I handled this case. We avoided here the mental nerve exit by inserting one implant in an angulation of 45 degrees, approximately 30 to 45 degrees. You can see the platform that we have here is in one level that is easy to be accessed afterwards. And you can see, because of the defect that we had here, it was not possible to insert anything in this area. As I told you, I am not very confident, especially if I have 3 walls missing or 2 walls missing of the bone, to insert also the implant the same day. I wanted to do a more easier work for my patient, a more easier rehabilitation of this mouth, and I saw the opportunity to place the implant with this angulation, as you can see here. It's almost parallel to the jaw. This is 60 degrees. That's why the 45 degrees angulation of this multi-unit is not exactly in the level that I would like it to be. It's almost, it's a bit more. We still augmented the area because we didn't, and I'll explain you how we augmented this area. Because I didn't want to have any defect, especially here on the threads of this implant, and afterwards in the final prosthetics. It's actually a very fresh case, very new. We've done this last month, and we've placed collagen sponge to the bone, augmented material in the middle, collagen sponge. That's why you see these lines, and above another layer of bone. Why we did this? I did this because we had as we all know, bone is built from blood. If we have a blood collection with the collagen sponge in this area, it works also antibacterial, but it works also with a bone building. We close this under, we left this under the augmented material. Sorry for that. And we covered everything above. I'll be glad to send you some pictures some months after, when we see the final results of this. Stay in the group and you'll see this, the final, how this works, this surgery went. Here you see the augmentation that we did with the sponges above. We didn't use any membrane. And you see how parallel this, and what I mean that the angulation here of 45 was actually not enough. The restoration will be in position, but is not this preferable that I would like to have. Here again, the limitations and the final result, and we avoided the mental nerve and the mental foramen at the same time. So if anyone have some questions, or if anyone can reach me, you can find me in WhatsApp, Instagram, or email, or directly in this group.
If anybody of you has any questions in the future, you feel free to contact him and ask the question in this group, so he can share the experience with you.
Surely you can discuss any also other cases of other colleagues if they want to find some solutions. I'll be very glad to answer or give them solutions for their cases. Anyway.
I hope that this information which was provided by Dr. Kyriacos today was useful, and you can use it in the future. After this video is out, please share it with your doctors. Otherwise, I want to thank everybody who took part today, and especially Dr. Kyriacos. Thank you very much.
Thank you for the opportunity, Artyom. I would
Thank you.
To have some other lectures later, maybe explaining more about these techniques. We are collecting material through our surgeries in our office, and we'll be able to have. We'll see also in the group what the most of the colleagues want. If they would like to see more pterygoids, if they would like to see more the palatal approaches, and see solutions that they can solve their problems. I will be glad to offer another lecture with these techniques.
Thanks very much for everyone. Have a good evening, and I will be in touch with you about the next webinars, about the record of this webinar. And again, special thanks to Dr. Kyriacos. Thank you very much, and see you later.
Bye-bye.